Right, okay, so next we're going to talk about weaning. Weaning is a pretty big deal on the intensive care unit, and it's the process by which the work of breathing is taken from the machine back to the patient. It takes up 40% of ICU bed days, so it is a big deal, as we said. And if you get a question on weaning, you should also talk about how you minimise the duration of ventilation on the intensive care unit. So you say, one of the most important aspects of weaning is to minimise the damage caused by duration of ventilation, and there are some strategies that can help achieve this, and we'll talk about those later. Okay, so you need to think about when are you going to start weaning the patient, and I think about RNA-C, but you can also think about ABC. I do RNA-C, so reversal of original pathology, neuromuscular function adequate, and that's going to basically include breathing and cough. So adequacy of oxygenation, and also any procedures planned. If they're about to go back to theatre, there's no point in whipping the tracheostomy out. And C is cardiovascular stability. Okay, so before we think about weaning a patient, we've got to give them the best chance, and the way to make sure that they've got the best chance is they've got minimum airway resistance, and maximum airway power, or maximum breathing power. If you want to roll a ball bearing up a pipe, you want to make sure that there's no bumps in the pipe, and you want to make sure you've got the most strength to push that ball bearing up. So reducing resistance, we make sure we treat bronchospasm, we make sure they've cleared all their secretions, that helps compliance. You optimise their position, and part of that is you considering the intra-abdominal pressure. Think about this big fat person here, and they're all bunched up in bed. All their rolls of fat are all pushing up on their chest. They're going to really, really struggle with their breathing. So you treat their bronchospasm with an inhaler. You make sure their secretions are cleared with good physiotherapy. You sit them up so that they're a bit happier, and you think about what you can do to reduce their intra-abdominal pressure. In order to make sure they've got most power, you need to think about, have you given them enough food? Have you had a proper sedation hold so that they're fully awake? And you minimise the use of neuromuscular blocking drugs. To make sure they've got maximum strength, you make sure they've had lots of physiotherapy all throughout and early. Their electrolytes are normal, and you haven't fatigued them with loads of other work beforehand. And you make sure you optimise their drive to breathe. So again, that's about sedation, analgesia. Okay. So how do we know if we're going to fail? Well, it's going to be an old person, probably with COPD, who's been ventilated for a long time. He's got a very positive fluid balance. He's still got loads of secretions on board. If they're confused, or they failed a lot of times on the spontaneous breathing trial, or they're unable to cough, or their pathology is mnemonic, you're going to struggle. Also, medical patients versus surgical patients are more likely to struggle. So I'm just going to go through that again. And here we have a picture. So we've got this old person here, and they're in loads and loads and loads of water. So they've got a positive fluid balance, and they've been on this guy for days and days and days. It's a prolonged one, and they're confused, so they're not going to do. And look at this big fat chap. Loads and loads and loads and loads of mucus. They're also medical. Got COPD. They can't cough. There's a poor cough. And she's got, and you can't see, I'm going to put a little cigarette in her hands. So she's a heavy smoker as well. So she is not going to do well. So one of the ways we can predict whether people are actually going to do well is you can do a rapid shallow breathing index. That is frequency divided by tidal volume in litres. So just thinking about a patient that's breathing 30 a minute at a tidal volume of 0.5 gives you a rapid shallow breathing index of about 60. They might do. Breathing at 40, think about a patient that's breathing at 40 at 0.4 gives you a rapid shallow breathing index of 100. Do you think a patient that's breathing at respiratory rate at 40 with a tidal volume of 0.4 is going to extubate? I don't think so. But then conversely, what about a patient that's breathing at 20 a minute at half a litre for tidal volume? They got a rapid shallow breathing index of 40. I think they'll do. I think they won't do. I think these guys, that worries me, a respiratory rate of 30. One of the more commonly used methods now is a spontaneous breathing trial. It can be used both as a weaning strategy and also to determine if they're suitable for extubation. If they can manage half an hour on a trachea mask with no assistance, they're probably going to do okay. Now I can't really think of a way of defining this, but if they fail, their respiratory rate's over 35, their heart rate's greater than 140, or their SATs are less than 90, or this has gone up by 20%, or they are pouring with sweat, they're not going to do very well. Esteban et al. In 1994 trialled a once daily breathing trial versus multiple daily trials, and this led to extubation 3 times quicker than weaning on SIMV and twice as quickly as PSV. Some doctors advocate using NIV into weaning, so this works for patients with COPD. So again, the smokers. Yeah, these guys, they may do well with early NIVs. Early extubation to NIV is better than prolonged ventilation, but you've got to choose the right group, so that's a pretty unhelpful statement. But you should use it in planned circumstances and don't use it as a rescue technique. That's going to fail. Okay, so just to talk about that thing that I wanted to talk to you about at the beginning, which is one of the best strategies to successful weaning is to also minimize the duration of ventilation. So how do we minimize the duration of ventilation? Ventilate them properly. Low tidal volumes, well, not low tidal volumes, but normal tidal volumes. Barotrauma, that's volume trauma. Atelecta trauma. Mechanotrauma. You've got to avoid those things. Daily sedation holds, it's like a fundamental part of ICU care. Early physiotherapy. You need to be conservative with their fluid balance. Avoid VAPs, obviously. And this one's a bit controversial. There's some evidence to say that if you use the BNP to guide diuresis, you may help them. But certainly the FACT study did suggest that in ARDS, low conservative strategies is better than liberal. So the mnemonic for that is cabled, and I'm just going to go through it again now. So cabled. C is conservative fluid balance. A is avoid a VAP. B is BNP guided diuresis. L is low tidal volumes, which is a bit sneaky because that's not ARDS, low tidal volumes. E is early physio. And D is daily sedation holds. Makes sense. I really don't like this one here because really I like to think of this as ARDS because this covers a hell of a lot more. But that won't work. So unless we can find a way of switching these two around, could be L for look out for VAP. And A for ARDS. Net. Whatever. Anyway, hope that's helpful. Thanks very much. Bye bye.